Good day and welcome to the webinar today on the 1st of November. IndePractice Presents today, a webinar comprised of compliance issues that will affect your reputation. I
think we've had a little
in medical practice, and also some information on remote patient monitoring. So we're a specialty company that focuses on medical practices, and our sponsors for today's webinar include VenOps and the Medical Association of Georgia. Our first presenter is the COO, Chief Operating Officer of VenOps, Stephen Maloney. And without further ado, I'm going to give Stephen the ability to share his screen. So Stephen, without further ado, the floor is yours, sir.
Thank you. Okay, and of course, if there are any little technical difficulties or glitches, please let me know. Well, good afternoon, everyone. I'm Steve Maloney, the COO of VenOps. I'm going to give a short presentation this afternoon just about basic elements of a compliance program that includes specifically OIG screening compliance. There's a few slides here just to get us started. Once again, the background and essential elements for an OIG screening compliance program. That's for exclusions and sanctions. A couple bullets here to get us started here. I'd just like to go over the why, the how, the who, the when, everything about screening. Something that is still sort of largely being discovered by a lot of practices out there, and then once discovered, further discovered to be a little bit more of a complicated compliance item than once originally thought, and that's where we come in. So the who and the when. We're going to show you how to avoid the penalties, or how the penalties are assessed in the first place by OIG. We're going to go through navigating the OIG's LEIE list. That's the list of excluded individuals and entities, what we affectionately kind of refer to a lot of times as the grandparent of all the lists from the federal and state side. We'll go through how to or basic considerations for establishing a screening process, and then just a few recent enforcement examples. So without further delay, why should you care about OIG exclusion compliance? I'd like to go straight to the main reason. It's a basic compliance program item. It's defined within the 7 primary elements of any compliance plan. And so it is right at the top of the list, or near the top of the list, for consideration for inclusion. You mitigate that overall risk and the risk of fraudulent claims, so it leads directly into one of the more overarching compliance plan items, which is the billing. It maximizes your resources, time in particular. A third-party screening solution is going to save an incredible amount of time. And we can just go into the particulars on that as far as the scope of any screening compliance program is concerned, as far as the number of the lists out there for consideration, just as far as the industry standard. It maintains an audit readiness aspect. Will always be a paper trail for your reporting. Moving on is risk mitigation for that CMP liability, that primary item as far as why we screen. It's all about the civil monetary penalties, which are practice ending in many cases and exponential very quickly. Guards the reputation of any organization, and it meets, as far as one of the newer requirements, more and more attestations are required for participation, in particular with insurance. Next slide here. VenOps, we are a trusted solution for OIG compliance. We're founded in 2014, have a varied background from all of our experts in healthcare, finance, and sales and regulatory affairs. We currently serve over 1,000 organizations Private practice, home health, hospital systems, pharmacy have assembled a host of tools to directly cater to all of those different quarters of the healthcare world. We have a high client retention and satisfaction rate, just to speak to the ease of use of the system as a solution for compliance, 99% plus. Accuracy is the cornerstone. No screening program is going to be without its accuracy. Everything has been built along those lines. Automating is the automates a core compliance, but I was also going to just briefly mention that automation of the system is also just a core aspect of it. It needs to be repeatable, fast, sort of the same along the lines of the same basic tenets of perhaps a bad diet, as I joke. And then here we just have a nice just to kick things off with a nice testimonial.
Stephen, we really can't see your screen. Your PowerPoint's not moving.
Do you see a screen there with three bubbles?
The only thing we see is your first PowerPoint, which is your name and your picture.
Oh, excuse me for a second here. Let's go with, how is that?
Now I see 3 bubbles.
Okay, there we go.
Thanks.
Well, apologies, you guys. Moving on. The next slide is just about exclusion and sanctions. So what they are, how they happen. First thing we do is we just want to define the difference between an exclusion and a sanction. Sanction is a result of an administrative hearing regarding violation of an administrative rule, a civil law, or a criminal offense. And you can further define those into exclusions. There are 2 types of exclusions when it comes to the OIG. You have mandatory and permissive. Mandatory, of course, is no matter what, 2 + 2 = 4. It's going to result in an exclusion, versus permissive may or may not result in an exclusion. There's some workarounds in some of those cases. And then there's a quick few bullets there for each. Excuse me. Quick note on reciprocation. I'd like to add this in there. The list for the state and federal exclusion authorities are very dynamic. They change quite quickly from month to month, in a lot of cases even from week to week. And we do monitor all of those. It basically states, as you would expect, any state Medicaid program can terminate any individuals or entities' participation in the respective services simply because they have been terminated on a federal level in particular, but lesser known is also from state to state. That's an Affordable Care Act mandate. It's one of those items that is still, relatively speaking, not across the board enforced, but there is a sort of a critical mass growing as far as that. Every compliance conference that we attend, it's one of those items that always comes up. Everyone is keeping their ears and eyes open for it. Something to consider, and when that really gets going, it's going to continue to greatly expand the program and the need for a good solution. Here are the effects of an exclusion. Though federal healthcare program payment can be made for any items or services furnished by that excluded person, at the medical direction of an excluded person, or on the prescription of an excluded person, that's just the overall umbrella definition. Reimbursement for items and services must be repaid, and civil monetary penalties are also added on there. And as I mentioned, they do compound very quickly. They become relatively exponential just by payments, by everything that person or excluded vendor entity had a hand in. You've got the primary application that I just mentioned. However, it also includes items and services beyond direct patient care, and you can see the list there. includes everything from preparation of surgical trays, everyone who's paid, anyone who has a hand in that, administrative and management services, the executive, the IT, staff training, HR, your transportation services. I probably should throw in, I don't think it's included, imaging, for example, with a private practice would also apply. Next slide.
What about vendors?
Vendors
All
also
vendors?
apply. Yes, well, for example, well, 1-800-Flowers would not apply. They need to be associated in the provision of healthcare. So McDonald's, Jimmy John's, 1-800-Flowers, imaging services. However, it's important to note that a lot of times, as far as vendor screening is concerned, when your HIPAA considerations do not apply to exclusion considerations. Simple patient care or contact with patient care areas does not apply for exclusions. That has to be money changing hands. There are payments involved.
That makes sense. So like lab services, bracing, any outside vendor services that in any way affects billing with Medicare, Medicaid, any government insurance, right?
Absolutely. DME is a big one to consider.
Okay, thanks.
Okay, next slide. Who to screen and when? Regulatory requirements, government expectations. We've gone through who, how those exclusions occur, how those sanctions occur. Who to screen, in short, it's like I alluded to, anyone or entity that is paid directly or indirectly. This surprises a lot of folks when it comes to contracted physicians, for example. A good document to review on this, and it's not on the screen, would be the self-disclosure protocols that would be activated if an exclusion were ever to be discovered in your organization. That is your Bible, and it really gets more into the details as far as the applicability for contractors, for example. So again, in short, any person paid directly or indirectly, their HHS guidance on screening does exist. It's all over their website. But the specific guidance is prior to employment or contract and periodically. So pardon me for a second. When to screen actually should probably be a sub-bullet there, apologies. When to screen, industry standard is monthly. However, that's the periodically, quote unquote, that's been added in there. But monthly is the norm, and for certain prior to hiring or professional association. At a minimum, screen the LEIE. That's your minimum level of protection. However, it has grown, as you can see, to include multiple federal and state, in particular the GSA System for Award Management as the federal, and then all but 2 states have lists. All but, I believe, Wisconsin and I want to say Utah. And then frequency, of course, is just touched on again. So we can just kind of skip over to the next slide real fast. CMPs. Now this just goes over Code of Federal Regulations, paragraph, section you're going to find this in. There is a base CMP for the employment of an excluded party, and then CMPs also are compounded for every payable federal health care program instance. You can find all of this by Googling that CFR segment, and also the OIG's website does include a breakdown as well. I've also included here on this slide just a general overview of federal and state lists. Are we short of time?
Yeah, we have to cut you off at 12:30, but so many acronyms. CMP means
civil monetary penalties.
civil monetary penalties, right? Good.
Pardon.
Now you can have another minute to wind it up. Great.
All right, I'll just skip ahead to the thing that everyone else really enjoys. Real briefly, you can absolutely navigate the LEIE manually. There are two possible avenues. You can manually enter in names one at a time. you can download the full list and then search that way. Dates of birth on the downloadable list, and there is a social security number version as well. A list of pros and cons. I can discuss ad nauseum, but as I'm being short on time, I'll just kind of skip over that real briefly. Step one through 6, determining screening process. Really determine your list you want to screen. Straightforwardly put everything that exists as far as state and federal Medicare lists. There's not much of an option to leave any of those out. Determine your individuals and entities to screen. Individuals and entities, that's everybody you pay. You're never going to go wrong with that. And with vendors, if you ever have a question, screen them anyway. The only question for screening people is, do you have the PII, the personally identifiable information necessary to investigate and clear them if you need to? Common names you're going to find those common names are potential matches as false positives a lot more often, but it's a good idea to screen everybody who is paid. You're going to determine your data requirements and resources. I just touched on that. Determine the individuals and departments responsible. Typically, it's HR. If you have a compliance officer, that would be your compliance officer's responsibility. The screening process, typically, it will vary by vendor. With VenOps, for example, it's a matter of submitting a formatted spreadsheet as many times as you need to, add more to it during the month. There are no limits for that. And then step 6 is just define your reporting and documentation standards. You will always have, at a minimum, the requirement to maintain an archive of those reports that says you did it, who you screened, who the possibles were, and how they were cleared. All of these are included typically with a VenOps, not typically, straightforwardly, always with a VenOps screening report. Ready at a moment's notice, downloadable whenever you need them. Recent enforcement examples. I want to say the average civil monetary penalty is about $102,000 as far as settling any exclusion case. That's not on the slide, but having reviewed that, that was for the year 2021. Every year it grows just a slight bit more. First example here are the organization called the Estates at Fridley. They agreed to pay $64,000. They allegedly violated the civil monetary penalties law by employing and excluded individuals. This one was found relatively quickly. The base CMP for the employment is around 20,000. So there was a hand in there clearly with some additional payment actions. Second and third examples as well. The third example there is a little bit more of a higher penalty, another simple case of excluded individual being employed. Important to note that each of these is not actual guilt involved. They were agrees to pay, they were settlement agreements.
Stephen, we're going to have to stop you there. How do they contact you should they want to pursue this further?
Welcome to contact me anytime, email me. I will discuss at length as much as you'd like the program, how to add a screening program, how to tweak your existing internal program. Happy to answer any questions and talk about it.
Thank you very much.
Great, thanks for your time.
Now introduce Mike Mastanda. He is the Senior Practice Consultant for Medic Health out of Florida, and they are a national company and expert in A to Z remote patient monitoring. Mike has been in this RPM field since 2020, and he's a graduate of the University of Florida. He's a Gator. So Mike, take it away.
Much, Mark, and thank you, Stephen. That was really excellent. Can you see my screen?
I see black. There we go. Now
All
I see
right,
yours.
wonderful. All right, so thank you everybody for coming and joining along here. I wanted to just kind of introduce the concept of remote patient monitoring. to the audience here. So very simply, remote patient monitoring, what it is, it's basically a tool that monitors patients with chronic conditions using our cellular devices. So think of this as like an intervention tool, perhaps, as your chronic patients, between visits, if you see them every 6 months, maybe every year. I know that if they have more serious chronic conditions, you're seeing them more frequently, but this is going to allow you the ability to be able to check in on them, make sure that they're following their care plans, that they're taking their medications, and you actually have an intervention or an RN there that will help step in if there's any abnormal or critical readings. Medicare, CMS, these CPT codes came out in late 2019, and then the program officially, formally in 2020. So we're about 4 years in, and the CPT codes are 99453, 454, 457, and 458. Quite simply, these are devices, your standard blood pressure cuff, your weight scale, if you will, glucometer, pulse oximeter. These are devices that are FDA approved. There's no Wi-Fi or Bluetooth to connect to. They just look for the closest cellular tower in the area. So we deploy those devices with that cellular chip. And, in my 2.5 decades, I guess, of management leadership, I remember Peter Drucker, management guru, who said, what gets measured gets managed, and therefore what gets measured gets improved. So, think about like when you go to the dentist, as an example. What are you doing the night before you're going to the dentist? You're scrubbing your teeth, and you're flossing, and you're making sure that you are going to get that gold star from that doctor. Well, same concept here, but we just apply it on a more over time with our chronic conditions. So wherever focus goes, as Tony Robbins says, energy flows. And how does that really kind of reveal itself in our patients? Well, what we've seen through a University of Pittsburgh Medical Center study is a 76% reduction in ER visits, hospitalizations, and rehospitalizations. So we boast here an 88% patient compliance. So if you are having challenges with your patients becoming compliant, making sure that they are not hospitalized or rehospitalized, this is an excellent tool. Not only that, but it will also generate follow-up appointments for you as well, and then it will dissuade those patients who really don't need to see you very as regularly. So it will free up your schedule book, your appointment book, and this way you're only seeing the most critical or the most important patients. Satisfaction scores we've seen also jump as a result of implementing a remote patient monitoring program. I already touched on obviously the readmission rates, but fun fact, and this is why CMS put these codes into play, they want to incentivize practices for incorporating a remote patient monitoring system because of the healthcare savings. Think about it. You've got a chronic patient over 65 who happens to get admitted into the hospital. That's tens of thousands of dollars. So if they can save that, there's some substantial benefits for CMS, for private insurers, and of course the practice and the patient as well. So although it's relatively new, just going into its 4th year, it is starting to accelerate in terms of growth. So you'll see a lot more primary care physicians, internists, and even your specialties like the cardiology, endocrinology, et cetera, start to adapt and utilize remote patient monitoring to help manage and intervene for their chronic patients. So that CAGR is about an 18% growth over the next 10 years, and we already have about 11% of the population, and by 2025 it's going to double again. Who qualifies for remote patient monitoring? Well, you just have to have a chronic condition. There's 21 different chronic conditions, but of course your biggies are going to be your hypertension, your diabetes, your obesity, COPD, high cholesterol, AFib, CHF, just to name a few. And they also have to have Medicare and a secondary insurance that will pick up that copay. We want to have this as a zero out-of-pocket cost to the patient. That's what we see works best, and the patients are most compliant when it's not coming out of their pocket. And obviously, there's not going to be that kind of fallback. And I'll just say that there's a lot of remote patient monitoring companies out there. We want to make sure you go obviously with a reputable company. Of course, goes without saying. There's a lot of them that are major players, and we've seen a lot of them kind of be more fly by night. So just make sure that you do your vetting. We're in network with all 50 states with the VA, so we've been vetted by the U.S. government. We're A+ rated with the Better Business Bureau. But really, when we talk about remote patient monitoring and its benefits, the biggest benefit is being able to make sure that your patients are not ending up in the hospital. So when we kind of talk about the tenets, we're increasing and enhancing patient care, the patient experience, increased revenue for your practice. If you participate in MIPS, there's also the added benefit of not having your patients be rehospitalized, but also you're increasing your own individual equity in your practice. And I know that there's a lot of challenges out there with private practices staying private and not being absorbed. So this is a great way to combat those threats, both economic and otherwise, so that you're going to hold on to your practice that you've built so hard to have. And then in terms of the revenue side of things, we're looking at about $160 to $170 per patient per month in recurring revenue to your practice. So that kind of will manifest itself in a couple $100,000 to over a few $1 million in just a short period of time over the course of a year. Medic RPM is one of the only remote patient monitoring companies out there that will offer a fully customized, full service, completely turnkey solution to your remote patient monitoring problem for your patients who are having difficulty managing their chronic conditions. So this can be literally bolted onto your practice for passive income, or we can customize it to precisely fit exactly what your workflow is. So if there's RNs that want to, at your practice, handle some of the monitoring side of things, or you want to be able to just pick and choose a la carte from all of our services, you have the ability to do so. We do also provide billing services as well. So all the way from eligibility check all the way down through billing and beyond. This is the one and only partner that you'll ever need. And then lastly, I'll just kind of talk about the profit. Everyone can see the big numbers on the revenue side of things, and we're billing under your NPI, and the reimbursements are coming back to you. But when the rubber really meets the road is how much are you kissing and putting under your pillow? And so that's kind of like why I like to give a very conservative glimpse into what type of profit can be enjoyed by your practice with zero work and zero upfront cost on your practice's behalf. So with that being said, I know that we're short on time. So if you'd like to learn more, if you want to have just a conversation, obviously no pressure, but there's how to reach me there, and I'm on LinkedIn as well.
Mike, that was well done. And we have another minute or so if there are any questions, but if there's not, looks to me like your email is on there. They can also email us here at the Medical Association, or email me at mmaloney@venops.com, or give us a call. Let me change presenters here. Stop that. Gosh, how do I do this here? There we go. All right, very good. That concludes the webinar today. Thanks very much. There'll be a recording available for anybody that wants to review part of it. And if you have any questions, give someone at the Medical Association of Georgia a call, or call Mike or myself or Stephen, or email us. Take care. Have a good day.
Thank you.